We are very pleased to have as our presenter today Dr. Stephen Abel. Dr. Abel is the Associate Dean for Students, Community, and Professional Initiatives at the University of Buffalo School of Dental Medicine. He's also the Dental Director of the New York and New Jersey AIDS Education and Training Center and Chair for the New York State DOH AI Oral Guidelines Committee.
Great. Thank you all. It's nice to be invited here, and it's nice to speak to you all. For me, the intention here is really to better inform each of you on oral health in general, why it is important for all of us, why it is particularly important for persons living with HIV disease, and how you can become advocates for oral health. There is a lot you can do to help out the team. So let's start here. In 2000, the U.S. Surgeon General David Satcher came out with an oral health assessment of where we were here in America. And what we know is that those who suffer the worst oral health are the poorest. They are the lower socioeconomic classes. They are the disabled. They are the medically complex. And with the greater risk for oral disease comes the further complication to their general health. So the big picture, and this became sort of a catch line in the 2000s, was you are not healthy without good oral health. And the guidelines, if they're not guidelines, but the assessment went on to talk about the dental care being the most common unmet health need here in the United States, and that there is a true link between oral disease and systemic health, much of which was preventable, or at least controllable, and that the disparities in oral health and access to care exist across the spectrum of ages, from the youngest of children certainly to the geriatrics, the elderly, the frail. And interdisciplinary care is necessary to achieve optimal health. Now, what do we know? We do know that dental caries is the most common chronic disease in children. Okay? 5 times more common than asthma, affects 50% of low-income children. There were actually reports that 75% of all of the caries in the United States were among 25% of the children. So the poorest of children in this country were really carrying 75% of the bulk of decay. Okay? Severe gum disease, periodontal disease, about half of the U.S. adults, and that there were 70,000 oral cancers diagnosed annually, okay, with 14,000 deaths. And that number isn't changing much, and it happens to adults rather late in life. Okay. So consider that we have the talk about creating a medical home, okay? And although most patients have a medical home, many lack a dental home. And children are 2.5 times more likely to lack dental coverage than medical coverage. Right? The number of dentists are declining, and I think you probably can get it that there are most dentists that will not accept Medicaid as a form of payment. Dentists often are not comfortable. In other words, they didn't receive adequate training to deal with special populations, such as very young children. They are often fearful about pregnancy. They also don't have enough information on how to comfortably and competently manage adolescents and adults with special needs. Yet, when you survey physicians and nurses, you find that few have had adequate training. 50% have had little or no oral health training. Nurses come across with no oral health training in their curriculum. We are working very hard, we being actually the federal government and state government and the AIDS education, to train other healthcare providers on doing oral health assessments. Okay? How to do a head and neck examination. Every nurse and physician should know how to do it. Okay? They simply, clinicians simply lack the fundamentals. Okay? We have over 110 million people in this country that do not have dental insurance. And the Affordable Care Act is not an answer for dentistry. So, in terms of behavior, tobacco use certainly affects periodontal disease. We'll talk about that in a bit. Tobacco use affects oral cancer prevalence, and alcohol affects oral cancer prevalence. Drug use can be associated with poor oral hygiene and gross caries. And we'll talk a bit about meth mouth. So what's the consequences of all of this? The economic and social consequences of oral pain, dental decay, and tooth loss are far-reaching and can result in social stigma. Oral pain can cause and does cause poor school performance in children, work loss in adults, difficulty chewing, and costly emergency dental visits. So let me add there that I was in a, after school, it was the Boys and Girls Club not so long ago. We were talking to about 25 kids in the room, and we simply said, so how many of you have a toothache right now or something in your mouth that hurts? And about 6 or 7 kids raised their hands. I mean, and one said, well, not today, but last night. Okay? So kids are going to school in significant numbers with toothaches, okay? And it is clearly affecting their performance, and it is clearly resulting in loss in days. Okay? We know that between 2008 and 2010, 4 million people visited the emergency departments in this country. That's $2.7 billion, or it comes to around $500 to $700 per visit of persons visiting emergency departments for toothaches. It's not like it was an emergency that they were experiencing. Their face wasn't necessarily swelling up, but that's where people are accessing dental care, a truly preventable situation. So I was part of a large Ryan-wide activity that went on called the SPINS Initiative, the Oral Health SPINS Initiative, that ended several years ago, part of the evaluation team at Boston University School of Public Health, where we looked at increasing access to oral health care for persons living with HIV in the U.S. What is the baseline evaluation? What do we know? So we had about 2,500 people from all over this country. Okay? So it wasn't a regional study, it wasn't a statewide study, living with HIV who had not received oral health care in the preceding year. What did we find out about these people in America? Okay. 48% said at some point they had a dental need and simply could not find somebody to address that need. 52% had not seen a dentist in more than 2 years, and 63% rated their health of the teeth and the gums as fair to poor. Okay? That's a huge number of persons living with HIV disease who had not been to the dentist in the preceding year or the preceding 2 years, and have simply said the state of their mouth was fair to poor. So who might those people have been? Well, those persons living with HIV are likely to be African American, uninsured, Medicaid recipients, and the poorest. And many of them were simply unaware that there were Ryan White funded programs where they could access dental services. They knew that they could get medical care, but somehow they weren't aware that they could also get dental care within the program. And we know that those with the lowest CD4 counts present with more oral lesions, more oral disease, thrush, okay? And the lower your CD4 count, there was a clear link with low salivary flow, so what we call xerostomia. So what is the importance of saliva in the mouth? Saliva in the mouth simply has an anti-cariogenic effect. It has the ability to lubricate the mouth, resulting in decreased number of caries, okay? Less decay. If you don't have saliva and you walk around with a dry mouth, your teeth are more likely to decay. You are more likely to have periodontal or gum disease. And talk a little bit about that and what all of our role is in addressing that. Each of us has a role. But for persons living with HIV disease, the more ill, the less saliva. Okay? For children, okay, there's a higher probability of hard and soft tissue disease because of the compromised immune system, a poorer access to medical and dental care, whether you're HIV positive or not, and a limited availability of fluoridated water and toothpaste. They just may not have in that household their own toothbrush, adequate toothpaste supply, or worse yet, living in a community where the fluoridated water does not exist. And we're finding here in upstate New York, there are communities now that are eliminating the fluoridation of their water supply. And that's an entire political discussion, but we know unequivocally, we know that fluoridated water supplies will result in reduced caries. Special importance of oral health for persons living with HIV disease is those lesions that may show up in the mouth may be the first marker for a seroconversion. In other words, more than once have I done an oral examination, found a lesion in the mouth which was the hallmark for a seroconversion. Right? So yes, dentists can be the first to pick up a person's HIV positive status. More likely, the lesions will show that there is a decline in immune function or a failure of therapy, meaning that persons are on their medications, may not be taking it appropriately, may be skipping it or simply taking it inappropriately unbeknownst to them, and as a result there is a failure of therapy and an oral lesion will present. So that's our role in picking this up. Your role is getting them into the dental office. Okay? We also know that persons with HIV disease, you or I or a person who is healthy, not living with HIV disease, well, if they were to have gum disease, it may be mild, it may be aggressive, or if you have a mouth sore, if you have a canker, you know how painful they can be, well, more often than not, persons living with HIV disease that are not really controlled or managed well, those lesions are particularly large, particularly painful, particularly aggressive. Think of a sore canker sore that you may have or somebody healthy may have, but exaggerated 5, 6, 7, 8 times the size. Then you can imagine how painful it can be. And if it is that painful, then it is truly affecting their HIV treatment compliance. And certainly anecdotal reports suggest that patients who are experiencing oral pain or the xerostomia, which makes it the dry mouth, which makes it difficult to swallow, they are less likely to adhere to an HIV drug regimen. So if it is really difficult to swallow, you may not be taking your medication. You may find it just plain too difficult. So we want to be able to avoid all of this, and this is by getting them into HIV preventive care, oral health preventive care programs. So the indirect benefits of an HIV oral health service is that you treat the conditions in the mouth that can exacerbate wasting. Those lesions in the mouth really, really make it difficult to swallow medications and make eating just plain uncomfortable. The chewing of foods, the speaking, the pain associated with these lesions, the head and neck pain. Additionally, the reduction or the delay of disability and the improvement of quality of life. So I think I tried very quickly there to make the case of why dentistry is important in general, and how HIV can impact upon an individual's oral health. It can impact by the xerostomia associated. It can impact by increased prevalence of decay. It can impact because the lesions that are associated are particularly painful, are particularly aggressive. And that all of these services are important. The services we provide are important, and that they're particularly important for those who are medically complex. So could you say that people who are with immune systems are at greater risk for infections in their mouth? Yeah. So that was a question that was just put in front of me here, that as your immune system deteriorates, you are clearly at greater risk for infections in their mouths. You are clearly at risk for more and different types of oral lesions in the mouth. The huge canker sores are less likely to be found in somebody with a CD4 count of 500, 600, 800 and above. We find those lesions are almost linear and fall in line with the reduction in CD4 counts. Okay, so I lived here in New York City for 25 years, working in a HIV dedicated, establishing an HIV dedicated clinic here that was called St. Clair's in New York City, the first of such in the country, and then went to work for 8 years at the AIDS Institute, where I served as the oral health director. And what we did there was put together a directory of providers and sites that were Ryan White funded that had dental care facilities. And I see there's a question here of, so where do I find that site? And it's a great question because I know that the AIDS Institute keeps an updated online log of our facilities in New York State that are Ryan White funded that provide dental services. I know here in Manhattan that there are multiple facilities, and I truly mean multiple, okay? There to be well over a dozen clinics, whether it be at Harlem United or up at Columbia or in the dental schools. All of the dental schools participate in Ryan White programs where the schools are actually funded, as are the hygiene schools, to do the training of their students and ultimately to provide the care on site there. So while I can't tell you what the site is, I know that it is up there, that it is still up there. I'm kind of looking at this question to see. I'm not aware that Ryan White still funds these facilities. I am quite aware that Ryan White does fund some of the facilities that I am speaking of, the dental schools, for instance, and the community health centers, the FQHCs that are here. Some of the greatest numbers of funded sites through the dental reimbursement program through Ryan White are here in most of the hospitals in New York City. Once you start to get out of New York City, then we have a real problem. And I would agree with that. Once you get outside of Westchester County, you can go up to areas of Syracuse, Buffalo, where accessing dental services for Ryan White does become a problem, a real problem. And we're relying on the hospitals to meet the care of the underserved, and we are looking at the federally qualified health centers to meet the care. Okay. And we'll see what we can do about getting those dental services out to all of you on this call. So the dental service funded sites so that you will have access to know where you can refer. In the provision of basic outstanding, the coverage for basic insurance for Medicaid. Let me read this again. Since oral health is critical and a warning to many other systemic diseases, why it's been excluded from inclusion in the provision of basic health standards and basic coverage in Medicaid. So actually, if you look here in New York State, there is a very robust medical formula, dental formulary for adults who are covered by Medicaid. While it wasn't mentioned for the last 7 years, I had been down in Florida at another dental school, and your adult Medicaid formulary, adult, period, for all adults, consists of one oral examination, just an examination, an extraction under emergent situations, and you get one denture in a lifetime. You may get a partial denture and then get a full denture in a lifetime. Okay? And that would be your dental formulary. Whereas here in New York State, certainly basic preventive restorative services, denture services are covered. So these are state decisions, okay? It all depends on how generous the state chooses to be with adult formularies. The formularies for children are mandated, and those are comprehensive across all of the states. But one of the easiest things to drop is adult Medicaid when states are in fiscal problems. They did it in California. we still managed to keep it alive here in New York, largely because of some robust advocacy groups. How often should a person living with HIV get an oral examination? Once a year, once every 6 months? That's the question. So let's ask the question, how often should an adult, any adult, get an oral examination? And there really isn't great evidence on that. While you may see here on television, go get your mouth checked every 6 months, the true evidence that supports that is not in. That was really a Madison Avenue slogan. What we could say, has to be adjusted, tapered for the individual. So if you are at risk for developing caries, as many young people are, then you certainly would want them to be accessing dental services at least once every 6 months. And it could even be greater than that if there was aggressive periodontal disease. For an individual who really doesn't have decay much at all and keeps their mouth very, very clean, it might be closer to annually. Most insurance companies will pay straight out for his services every 6 months. I could well imagine that as the evidence gets stronger, it may start to be closer to once a year unless there is demonstrated history of recurrent decay. And what age should a child start going to the dentist? Well, if you looked at what the pediatric guidelines say, they could be as young as a year or two just to get them into the chair to have a wellness visit because the first tooth will start budding through. Certainly by year 2 or 3, the child should be to the dentist, but could be younger than that. Most of them are seeing the pediatrician early on, and in this state and others, pediatric medical offices are being compensated to provide fluoride services to children who may otherwise not be getting the dental visit. But if the question was asked by the mom, what age should I get my kid for the first visit to the dentist, you could say a year. Okay? Certainly by 2 years old, and absolutely by 3 years old. That's getting late already. Okay. So let's move on to some of these. Let's see if I can get this going. Okay. So okay, so we're a little stuck here, so let's see if we can get somebody to help this going. There we go. Okay, so excellent. So you start to hear, well, there are these real links between oral health and systemic health. Is it true? Okay. And is it a causal link? In other words, poor oral health results in systemic health problems, or is it casual? Okay. So we're not going to go through this, but basically it all boils down to the inflammatory response. So you eat food, you leave it on your tooth, plaque develops, there's 500 different bacteria, that is 500 different species of bacteria. Those bacteria give off toxins that damage the gum tissue. Then your inflammatory response comes in, the neutrophils, the white cell counts. White cells come to the area to start to clean up the inflammation, the macrophages then come in. They release all of these toxins, which then get into the bloodstream and start traveling about. And it is that what they call the inflammatory cascade, with things such as pro-inflammatory mediators, interleukins. That is all I will get to, because people are saying, what are macrophages and neutrophils? Think of them as your white cell counts, your white cells whose job it is to fight off infections. Okay, so as they're fighting off these infections, they're spilling off those chemicals which are responsible, okay, and those chemicals are leaching through the inflamed blood and running throughout your system. Okay, so what? What are these circulatory inflammatory mediators doing? Well, we think, and we know for sure, that there are relationships between diabetes, heart disease, stroke, pregnancies, osteoporosis, and respiratory. Okay? And you might have seen on commercials, well, you know, gum disease can lead to heart disease. Well, let's look at that. Here's what we know for sure. We know for sure that persons who are diabetic are 3 times more likely to develop gum disease. Okay? And if they're smokers, they're 20 times more likely to develop gum disease. Okay? And interestingly, those people who have gum disease have a more difficult time maintaining their glycemic control. So in other words, their nurses, their physicians are challenged by keeping their blood sugar in control just because they have gum disease. So there's a link there. Something about that gum disease is affecting their diabetic control. Okay? And those people who are diabetics, and you can ask, I'm a periodontist, ask us all, their ability, they're showing up with severe periodontal disease frequently, just by the nature that they have diabetes. Okay. Now, what we know less for sure is that those oral bacteria can affect the heart simply when some of the bacteria that were associated in those plaques can actually get into the bloodstream, and they attach to the plaques in the coronary arteries. And those cytokines, or those inflammatory markers, okay, can circulate, and we find them in enhanced numbers for those persons with coronary heart disease. Okay? And that smoking is associated with both persons with periodontal disease and coronary heart disease. Okay. How about low-term babies? And this is something that 8 or 9 years ago, it was a flash that went out there to the community, that periodontal disease in pregnant women will lead to an enhanced rate of preterm low birth weights. We didn't know why, but there had been 1 or 2 studies that showed this. And with that, there was enormous concern and much larger studies. And the studies now are saying the following. Persons who are pregnant can get dental care, should get dental care, because their periodontal disease, we used to thought, well, they can't have their teeth cleaned because the bacteria during the teeth cleaning process are going to spread. No, no, no. Okay. Women who are pregnant should get their mouths clean. Okay. It's safe during pregnancies. Okay. They felt better during the treatment. There were no negative prenatal outcomes incurred in any of the major studies. However, in the larger studies, we were not able to demonstrate that there was a reduction in preterm deliveries among persons who had no periodontal disease versus those who did. So right now we can't say for certain that if you are pregnant, going in and having your mouth cleaned is going to reduce the likelihood that you will have a preterm child. We can just say that you can safely have your teeth cleaned. Okay? And what we're looking at now is, you know, maybe it's too late once you are pregnant to reduce your likelihood of preterm by having your teeth cleaned. And now the studies are really looking at women who plan to become pregnant. Well, part of that plan should be to get your mouth in shape, reduce the biobacteria in the mouth, both by reducing caries and periodontal disease, if you're really interested in reducing preterm babies and low birth weight babies. Okay. Osteoporosis, the studies are suggesting that those who experience osteoporosis are also experiencing some level of osteoporosis around the supporting bone in the jaw, and that is resulting in periodontal disease. In other words, you're losing the bone around the teeth, which is resulting in tooth loss, mobility of the teeth. Okay? We do know, however, that scientists can show that the oral bacteria in a mouth can be aspirated into the lungs and can cause respiratory diseases. And what we really know, in those who run nursing homes, is that one of the leading causes of death in the nursing homes from aspiration pneumonia, and it's the aspiration of the bacteria from a rather dirty mouth. Okay, so for the bedridden or the hospitalized, we know that cleaning up the mouth is critical to avoid respiratory diseases. There are numerous well-documented instruments, the oral health quality of life, which can show that pain associated, the embarrassment that they're associated with poor oral health, that those who they are less likely to socialize when individuals present with poor oral health, missing front teeth. They're clearly less likely to socialize. I was involved in a domestic violence program not so long ago where we went into the facilities where women and their children were there for 6 or 12 months through a comprehensive rehabilitation program. And the role that the dentist played in putting together the mouth in restoring the broken teeth in the front that were part of the battering experience, okay, all contribute significantly to the overall rehabilitation, the readiness to return to the workplace. So the avoidance of social contact, the depressive effects are real, okay? And it is something that we can do about. So we have this mental health component that is associated with impaired oral health. We have the systemic health component that is associated, and while it may not be causal, we are clearly seeing that there's relationships between the two, where science is still working to say, yeah, are those relationships coincidental or are they casual? And there's probably area in between where it is. But there are actual direct bacterial extensions, and you may be familiar with the Diamante Driver case in Maryland. That is the worst case scenario, where the intraoral abscesses, the bacteria just got through the facial planes or spaces in the mouth, resulting in the swelling, resulting in sepsis throughout the body, resulting in intraoral abscesses, and can even result in the brain abscesses that resulted in death. We know there were about 110 such cases documented in our operating room, in the emergency rooms. Okay, seems to be a small number, but this is a very, very serious situation. Avoidable? Yes, by making the referral, by encouraging the young person, the mother of the young person, to access the care. Can persons get care? So this study went back to 1994, where I was involved with Dr. Glick, who is now my dean up at Buffalo, and myself. We looked at 331 patients here and in Philadelphia. That's when people were walking around with CD4 counts of 71. So they had frank AIDS. We did 1,800 invasive dental procedures. We caused bleeding in our clinics. The post-procedural complication incidence. What does that mean, a post-procedural complication? It was delayed healing. It was bleeding. It was bleeding that went on for longer than we would have anticipated. Okay. We had pain that wasn't controllable. Okay. Wasn't readily controllable. So these were all situations where the post-procedural outcomes were really not normal. They were exaggerated. What was the complication rate? 0.9%. Okay? So we knew that this incidence of extractions, what is the complication rate of somebody's having their third molars taken out, their impacted molars? About 3%. What is the complication rate among those who are having HIV disease who have the same? About 3%. So this study and most studies support the conclusion that persons living with HIV disease, the post-procedural complication is no greater among the HIV positive patients than in the general population. That was a critical, important finding that we made in the 90s that began to change the way our entire profession looked at the population. It was no longer acceptable to say, I can't treat a person with HIV, so I don't have the expertise, I don't know how to handle the complication. Okay. Well, we have seen to it that they do know how to handle the they do have the expertise in management. It's been the role of all of the dental schools in the last 20 years. It's been the role of continuing education. It's been the role of the AATCs. Okay? It's no longer an excuse that you do not know how to treat. And it is no longer an excuse to say you can't effectively manage the complications because the complication rate is no different than the general population. That argument would mean that you couldn't handle any patient if you can't handle the complication of an HIV patient because it really is no different. So, knowing then that the complications are no different and that patients living with HIV can and should accept and can be treated in any dental setting, what should we be telling, what should you be telling all of your patients? What are the preventive steps? What are those preventive messages that need to be reinforced? Well, not so different than any patient. Okay? You have to brush and floss regularly to keep the bioburden, the number of bacteria, down in the mouth to prevent that inflammation. Okay? Not only because of the systemic effects that it may have, but the local effects that it should have. Avoid snacking on the sugary foods. We know that your incidence of caries, cavities goes up, really based on the number of intakes. Okay? Fluoride toothpaste is essential. Okay? Minimize medications with oral effects. Well, that's something you can't tell the patient, but we tell the physicians and nurses that there are associated xerostomia with some of the medications. Okay? The fluoride toothpaste is critical, and alcohol and tobacco certainly have local effects in the mouth in terms of increased oral cancer, which is an exaggeration, but not necessarily an exaggeration for the heavy tobacco user or the heavy alcoholic. Okay? The xerostomia associated with the alcohol is certainly real. Okay? Twice a day, soft toothbrush. Yes, there are, yes, a soft toothbrush, not a hard toothbrush. I don't know why they make hard toothbrushes. I don't know why they sell them. We used to say 30 years ago a hard toothbrush cleans better. No, a hard toothbrush removes plaque no better than a soft toothbrush, but it does cause recession, greater recession than a soft toothbrush. Okay? Some patients will get a better result using an electric toothbrush. That's generally a call that the dentist or hygienist can make. We certainly know that everybody doesn't need an electric toothbrush if they can do a good job with the soft toothbrush. And the flossing is essential. Okay? Are there cases when a patient should see a dentist who is experienced working with HIV positive? In other words, is there a role for visiting the HIV, we'll call it, oral health specialist? And while there isn't such a category, as we do see that there are, the HIV Medical Association does have enhanced training where there are physicians and nurses who can call themselves HIV specialists. We don't have it. But what is the benefit by seeing somebody like myself that has more experience? I think that if there are lesions associated with the mouth, that going to somebody who has more experience can be an enhancement to the care. I think that there is certainly a piece of it that comes with more experience means also more sensitivity to the lifestyle or to the status, that those with more, you're likely to experience absolutely no stigma associated with your HIV disease than in an office where you may be the only. But in the largest part, for the majority of persons living with HIV disease, their oral health care is not significantly different than the person without an HIV positive status. Okay, it's good oral health care delivery is important for everybody. Okay, it's more of a reinforcement. It's doing a very good oral examination. I think somebody like myself is more likely to pick up an oral lesion, a very small oral lesion, than those dentists who are less experienced. So that could be a case for referring to an HIV specialist. And those who are with CD4 counts that are depressed, they would probably benefit by those. And those whose diagnostic lab values are lower, lower platelet counts, lower neutrophil counts, those are better served by a dentist with more experience. But you could have that low platelet count or low neutrophil count if you were not HIV positive, so a medically complex diabetic, for instance. So just because you're HIV positive does not mean your platelet counts are low, does not mean that you are necessarily going to have more lesions, does not mean that you're neutropenic or have a low neutrophil count. So it's hard to make the case why everybody should be seeing an HIV oral health specialist. For adults, keep the caries low, keep the bacteria counts low, keep the sugar low, the frequency of the sugar, and root caries. So you see, as you get longer in the tooth. That was from the expression as you age. Those roots do not have enamel on it. They are softer. They're more susceptible to caries. Okay? So keeping that part of the mouth clean is essential. So that's having an aggressive fluoride treatment. Okay? We have fluoride varnishes to reduce the caries incidence. The xerostomia in patients with exposed roots. Okay, 30% of people living with HIV experienced xerostomia, both from directly, there was some of the CD4 counts, but it's also associated with the other drugs that they are taking. Let's say the antidepressants have a direct effect on the xerostomia, directly associated with dry mouth. What do you tell the patients to do? Drink water. Keep the mouth dry. Keep the mouth wet, Avoid caffeinated. Caffeine will cause xerostomia. Keep the sugar out of your mouth. There are over-the-counter saliva substitutes. Use the fluoride rinses, and home care is particularly important. Okay, gum disease, not going to talk about it. Those are the pictures, the first signs of gum disease, all coming from that bacterium and food debris that are building up in the mouth. Treatment, home care. Get yourself to the dentist, lest the gingivitis, the first step, turns into more aggressive periodontitis, which now is really saying it's not just the gums that are inflamed and sore and red, but you are actually losing the bone that's holding in the teeth. We know that periodontal disease is more prevalent in persons with HIV disease. They need the definitive deep cleanings and antibiotics or chlorhexidine mouth rinses. Meth Mouth, we see it, it's real, it's associated with methamphetamine use, largely from increased carbohydrate use and poor oral hygiene. So what do we say? We say, get the fluoride going. There's over-the-counter rinses, Fluoride Act, understanding that they contain alcohol, and if you put in your head, while you can't prescribe it, this is really the answer. It's generic, it's prevalent, and it's a prescription toothpaste that has a fluoride component into it that's much greater than the over-the-counter. It is really the answer for patients that have xerostomia, for patients that have an enhanced caries rate. It is what is going to keep them caries free or keep the caries reduction down. Okay? How we all work together, it is a team. I hope I have given you enough information to say you don't have to be the guy with the drill in the hand, okay? You have to be encouraging the patient to get into the dentist for those oral examinations, to get that caries down, to keep the mouth clean by the periodontal treatment or the 6 months prophylactic treatments, okay? We know that patients stay in care. We learned this part of that study that I was one of the authors. By oral hygiene education, that is what the patients want. Those messages, when they hear it, is what will keep them in care. The messages don't have to come from me. They can come to you, just reinforcing how important staying in care is, keeping their mouth clean, linking them to care, okay? Be certain that you have the consent, that you can call an oral health care provider to establish an appointment for them. Working as a team, we enhance the whole patient care, oral care outcome for our patients. That is my message of promoting oral health care and reinforcing my messages. You can do a huge amount to help every dentist out there to get the patients in care so that emergent situations aren't commonplace or aren't present at all. Thank you all for listening. We will do our best to make these slides available to you and to get those resources of sites where you can refer your patients. Thank you.